everyone, my name is Jordan Bombi and I'm a student physical therapist assistant at Jeff State, and today I'm going to be talking to you about the prosthetic use and gait assessment for a transfemoral amputee. So that's a lot of words, so we're just going to get some background information first on what transfemoral amputation is. So a transfemoral amputation is also called or known as an above knee amputation. This is a surgical amputation that will remove the lower extremity at or above the knee joint if it's severely damaged. And this can be damaged by disease, congenital defects, and trauma. So above knee amputations comprise of around 27% of all lower extremity amputations. So here is just some pictures of above knee amputations. You can see where it's been cut from over here on this one, and this is just some things that we'll get into further on. I just wanted to show you a picture of what transfemoral amputations look like. So what is the prosthesis? A prosthesis is an artificial body part. So in this case, it's the artificial lower extremity, and since it's above the knee, it's going to have an artificial knee, ankle, and foot component. And this allows an individual to be independent to achieve maximal functional ability for the years to come after surgery. So the length of the residual limb is actually very important when determining the use of a prosthetic for gait and support. So this information is important because there are many different parts to a prosthesis, and we'll talk about that in just a minute. So all of the factors will have an impact when determining the type, fit, size, and weight of the prosthesis for the patient. So things such as lever control, the amount of muscle mass, the amount of proprioceptive feedback, the degree of balance distribution, and the weight that the prosthesis limb is going to be, all is determined by the length that is cut during surgery. So some parts to a transfemoral prosthetic: you have the socket, which is basically like the quadricep or an extension of the patient's body. So this is going to attach directly to the residual limb. There can be two types: the quadrilateral socket or the ischial contaminant socket, and this will depend on how much balance and support is needed during gait. You also have suspension, which is a sleeve that rolls onto the patient's limb. So this creates a steel holding the residual limb to the prosthetic leg. Typically it attaches the residual limb to the prosthesis because it has like click, or the socket or the suspension has thing on the bottom that clicks into the prosthetic leg. So there are various types of suspensions depending on how active the patient is and what they prefer. You have shanks and pylons, which is the area between the socket and the foot and ankle component. So this can either have an endoskeletal design or an exoskeletal design depending on the patient and the desired weight of the prosthesis. You also have the foot and ankle assembly, so this provides the base of support, provides shock absorption at heel strike of gait, and it stimulates MTP hyperextension during the late phase. So different types of assemblies can be made depending on the patient's activity level. So here is just some pictures showing the socket, knee, shank, ankle, foot, and then another picture just showing it all as well. So knee mechanisms of the prosthesis. So it can all be determined on the activity level of the patient and how functional that they're going to be outside. So all of them have the same function at the knee though. They provide stability and stance. They provide controlled flexion and extension during swing and allow enough mobility for sitting, kneeling, or other activities. So just like any other prosthetic, the knee mechanism is patient oriented, so the patient can achieve maximal function and participate in all activities. So there are many types of knee mechanisms within the stance phase and the swing phase. So in the stance phase, you have manual locks, sliding friction, fluid resistance, and polycentric linkage. And during the swing phase, you have constant friction, pneumatic control, hydraulic control, and extension assist. So application and the use of prosthesis. The application of each prosthesis can be different depending on what types of prosthesis that the patient has. Each prosthesis can be made differently to meet the patient's needs, but each prosthesis contains the same parts that was discussed on the slide earlier. So now we're just going to talk about the normal gait pattern for a transfemoral patient. So this is what should be seen without any abnormalities during gait. So during the stance phase, which is heel strike to foot flat, knee is in extension, the foot descends smoothly to the ground. And then you're at mid stance. So once you're at mid stance, you don't want no more than 5 degrees of pelvic drop, minimum lateral bending, and base of support 2 to 4 inches. Then this is going to lead to toe heel off to toe off, which is terminal stance to pre-swing. Heel rises smoothly as the body moves over the prosthetic foot. The hip extends without lumbar lordosis. The knee flexes as the toe leaves the ground. Swing phase, the prosthetic knee bends smoothly. The leg swings forward in progression. Adequate heel rise for toe clearance. The prosthesis swings smoothly and quietly, and the knee extends just before heel strike. And you want step length equal on both sides. So you can also have gait deviations, which is an improper fit or length of the prosthesis could lead to various gait deviations when ambulating. And here is just a list of the possible gait deviations that can occur. So I'm just going to read some of them. You have knee instability, foot slap, pelvic rise, drop off, excessive heel rise, continuing whip, vaulting on sound foot, circumduction, and terminal swing. And since I don't have any video demonstrations or demonstrations to show you, if we can get it pulled up, then this is the video of a normal gait pattern for above knee amputation. As you can see, he don't have any, he's walking straight, has adequate heel rise, adequate pelvic drop to make it a normal gait pattern. So if you have any questions or comments, just comment below and I'll be happy to answer. Thank you.